Let's examine the way the newer agents are authorized. I mean, we're doing a little economics lesson here. Are the payers requiring step therapy? And in this disease, what is step therapy?
So the simple answer is it depends. And the reason I say that is there is a lot of variation both geographically, even within the same payer, and then by payers in terms of what they require. And there's a difference between Medicare and commercial insurance. And obviously, we're talking largely about a Medicare-based population since we're talking about an older population, but we see lots of fractures in people between the ages of 50 and 64. So commercial insurance comes into it as well, where sometimes step therapy is required, or they will at least inquire about, has the patient been tried on a bisphosphonate, an oral bisphosphonate? Have they been intolerant to or failed a couple? Have they tried other agents before you sort of move on? That's not across the board. And again, as a provider, I think if you can make a good argument that clinically, this is why I feel we need to start here, sometimes that works, other times it does not.
Do they need prior authorization?
Some of them, again, with Medicare and those drugs that fall under Part B, and denosumab and romosozumab fall under Part B as opposed to Part D. So then you're talking about medical benefits versus pharmacy benefits. Their prior authorization tends to be less of an issue in the non-managed Medicare group as compared to drugs, some of the other anabolics and all that fall under Part D.
I'll tell you what this sounds like to me. Back when we first introduced the statins, there were no generics. They were very expensive. And I heard from third-party payers, it's too much money. We're not going to leave it on the formulary. And I asked, well, what about all these folks who have MIs a year from now, who might not have had them had their serum lipids been controlled? And they said, not my problem. You know, I got to make my quarter. Does this sound to you like the same argument?
I mean, in a way, I think there's another segment of the high-risk population where the attractiveness of how these drugs work is going to be a harder sell, and that's going to be someone, let's say, younger but at higher risk because of really bad scores, where we really want to prevent the event. That's going to be a different challenge and hurdle, and I think, at least from my, I proactively try to communicate to a medical director this goal-directed, individualized treat to target therapy that I hope continues,
Going
at
forward
least to
into
make
the
it
future,
understandable.
do you see a complete shift toward these, I'll call them biologicals, for lack of a better phrase, away from the bisphosphonates, away from the standard therapies? Is this where we're all going? Given time, given price decreases over time?
I mean, I don't think the bisphosphonates, I think the bisphosphonates are here to stay. The one advantage that Dr. Singer pointed out is once you get to a place that you like, there's persistence of effect. So one of the patient I'm talking about, if you, younger but higher risk, if you use something and get them somewhere, then maybe you can give them a bisphosphonate and watch them.
Again, what I hear is, it depends. It depends. A lot of drugs, some drugs are good. Some of these new drugs are really good.
They are, and I think, again, from a patient advocacy perspective, part of what we've spent a lot of time advocating for is that, again, given the unique circumstances of osteoporosis patients and the chronicity of the disease, and as you've heard the doctors explain how it can vary so differently from patient to patient, having access to all of the treatments available for osteoporosis is essential.
All right, you know, this has been great, but now it's time to wrap things up. Why don't we go around and ask each of you for 30 seconds, your final crystalline thought, something you'd like to share with our viewers? Why don't we start here?
I think from our perspective, again, it's appreciating what the doctors are doing every day for their patients, and just, again, looking at those at highest risk for fracture, those who have had a hip fracture, those who have had any type of fracture, to consider getting them a DEXA scan.
Tom?
Well, first of all, thank you for inviting me. I would say to anyone who's concerned about their bone health, ask your doctor what you should do. For patients who sustain a fracture, my hope over the next decade is the standard of care will always be a risk assessment, evaluation, and treatment if appropriate.
Andrea?
If you are someone or have a patient who's 50 years of age or older and has had a fracture, that patient needs to be evaluated for an underlying bone condition. And we need to keep in mind, once we do diagnose osteoporosis, this is a chronic disease, so we need to take care of our patients and follow them over a lifetime.
Well, I want to thank all of you for being here. This has been kind of an eye-opening discussion for me in terms of risk. And some new drugs are out there. I knew new drugs were coming because there's new drugs everywhere. But thank you all. It's been just terrific. I want to thank you, too, for watching. It's nice of you to be with us. I hope you found this peer exchange discussion to be useful and informative. I'm Dr. Peter Salgo, and I'll see you next time.